it's also the leading cause of death for women, which I find incredibly scary, to be honest. There are 2 out of 3 people with dementia are thought to be living in the community. And so essentially this project, we're one of 2 PHNs that are working on this. The other one is West in New South Wales. So we feel very privileged to be working on this with the University of Sydney. And we're looking at recruiting general practices to look at upskilling and training the whole of practice to manage dementia in a way that becomes that we are bringing practices into the diagnosis of dementia earlier rather than later, and having it happen at a primary care level rather than a referral level. So why am I telling you all about this? I'm telling you about this now because in a month's time, when we start putting out some information to recruit, you're already thinking about it. Is this something we want to be involved in? Is this something our practice has capacity to do? Who do I need to speak to have that conversation? So we'll put some information out in our newsletters and things like that, so you've got a bit of information around it. We're still co-designing what that looks like. But one of the things I really want to do is make sure that you, as practice managers, practice nurses, know about these things ahead of time so you can start to plan and think about what you need to do, what conversations you might need to have, whose approval you might need to seek if that's how your practice works, and how you can create a buzz around doing an activity related to that. So when we get more information on it, we'll make sure we send it out. But I just wanted to let you know about that today. I'm actually going to hand over to Sharon in Geelong to talk about COVID. But before I do, I did mention the Practice Connect website, and we do have a new quality improvement page on dementia in there. So it's got a PDSA, some change ideas for dementia, and a bit of information on there on what links and resources they are. They are alarming statistics, and I don't like starting off a networking meeting with such alarming statistics, but I think it's a great thing to consider working on. If you want to be involved in that, by all means, let us know. Sharon, I'm going to hand over to you, and I will mute myself, and we'll see if all this technology that's working really well for us now holds up. Thank you.
Thank you. Thanks, Dee. Appreciate that. Just one other thing I wanted to talk to you guys about would be we're going to record this. So if there's any issues, if you don't want to be recorded, I don't think we'll see too many faces, but just in case, just letting you know that that's going to happen. All right, so I'm actually going to give you a quick overbrief of some new things that are happening in our COVID space. All right, so yeah, as I said, just a brief overview, guys. Don't want to bore you with too much. I shouldn't say that, but I don't want to give you too much more information about COVID. And all this information we've got, I will email to you anyway. So I'm just going to go over a few really important facts.
So it's just a really brief update. So the recommended uptake, ATAGI continues to recommend boosters for persons for which it's been 6 months or longer since their last COVID-19 booster or confirmed infection, whichever is the most recent, for that additional protection from COVID. We're going to send out these slides so you can see the booster doses listed below for those age groups and people of risk for severe illness, etc. Remember to update your vaccine service finder of vaccinations your clinic is providing. Sharon, can you switch to the next page?
Sure.
Next screen. So for program clinic closures, the COVID Positive Pathways program has ceased operations from the 1st of June. And care for COVID positive people will be through primary care providers. Barwon Health will maintain a COVID referral patient monitoring program, RPM it's called, reverting to inbound referral only model. So just to note, for residential aged care facilities, primary care providers are the main avenue for those vaccinations. So if you can encourage your GPs to provide vaccinations for their patients in the RACFs on their rounds. If you're not a vaccinating clinic, talk to the RACF about how they can assist with that process. And continue to encourage vaccinations, particularly when reviewing GPMPs, and offer to patients when they're presenting for their usual care. Next slide. So consider when you're looking at the workflow in your clinic, I feel like we're telling you guys stuff you already know, but just in case, consider using telehealth when appropriate, and strongly encourage the use of a video call. It's highly effective, much more than an actual phone call. Allocate appointments at the end of day for face-to-face respiratory patients or COVID positive patients. Make sure all your admin team are aware of the processes. I think in the last few years, people have realised just how important administration in general practice plays a role. So make sure that everybody is aware of how that works in your practice. Continue to ask questions when patients are booking appointments. If they've got a respiratory illness, ask them to wait in the car, encourage to bring a mask, use your online booking system effectively with prompts. Use available digital health tools like e-prescribing, health pathways, telehealth. If you don't know about those things, then reach out to us. I know that in Horsham and Ballarat, we've got a digital health person in the room from West VIC PHN. Sorry to Geelong and Warrnambool, but I also know that there's some good skill set in the room in both of those locations too, but you can always reach out to us if you want some more information on digital health, and we can connect you with the right people. There's GoShare packages available for COVID positive patients. If you don't know what that is, reach out to us because we can tell you what that is. And for Ballarat people, we've got the GoShare expert in the room. And for Barwon South West region, referral to the Barwon Health RPM program if the patient meets the criteria. So I think that's it from a COVID perspective. Sharon, are we right to hand over to, is it Mon?
It's Nat, and
It's
well
Nat.
done, Dee, on doing that. I got out of that presentation, so thank you so much. But it is Nat. The only other thing I want to add to that is we've got pages on your table. If you want to write any questions down, because it is so jam-packed today, yeah, please write anything down. We will send an email out with all your answers to your questions. Thank you, Nat, and I'll just get your presentation ready, hopefully a little bit better than the last presentation. Bear with me.
Do you want me to share it, Sharon? Because I've made a few changes just to make it a bit shorter.
Absolutely, would love that.
If you can I just take control, or will you stop sharing so I can?
I will stop sharing if I figure out how to do that.
I think it's stop presenting up the top in the middle.
In the middle?
It should be a red square.
Oh, goodness. No, that's leave.
I think you can just take over, Nat, if you want.
Let me go. I'll give it a go, hey?
That would be great.
Okay, so we'll just go stop sharing and I'll reshare. So we've actually got Nat and Mon, so happy days, you get both of us. So just while I'm getting the presentation up, so I'm Nat, the manager of our service delivery team at West VIC PHN, and then we've got Mon, who's the mental health manager. So we're just going to talk to you about step-through care, which is a new mental health and alcohol and other drug model that will commence from 1 July. So just let me get the presentation up. All right, so we're going to start by just showing you a little video. Oh, actually, let me just take 2. I wonder if it's sharing the sound. Bear with us 2 seconds. All right, let's take 2. Tell me if you can't hear it. Oh, you can't hear it.
No sound as yet.
Hold on, it might just be loading. I can't hear it either. Why can't I hear it? Take two.
A new service model
Yep.
of care is coming to Western Victoria. The Royal Commission into Victoria's mental health system
What just happened?
found that many people experience co-occurring AOD and mental health support needs. Blended treatment, care, and support is not readily available to everyone. Currently, there is a lack of integration and coordination across the health system. Until now, funding for mental health and AOD services has always been separated. To develop our model, we used co-design to listen to the experiences of our community and service providers. We learned that AOD and mental health service providers in our region were ready to work together in a more integrated way. So we have brought our mental health and AOD services funding together. We have structured our funding to encourage partnerships. Partnerships facilitate integration of services. Partnerships simplify the journey for a person requiring mental health and/or AOD care. Our partnerships demonstrate innovative models of care. Our partnerships address workforce challenges and how they can be overcome. Partnerships assist with providing care to local communities across Western Victoria. Funding is allocated to sub-regions to ensure that local communities have the services they need, where they need them, no matter where they live. People receive care that is centred around their needs in a coordinated way. Step through care, regional care partnerships, mental health and AOD. A new service model growing the way we deliver care across Western Victoria. A new.
All right, so we just wanted to talk a bit more about this model and really talk through, I guess, the key improvements that have been made, but also the referral pathways. So how do GPs and other providers in our region refer through to this model? So as we mentioned, it will commence in 1 July, and we're working with a range of partners across our region to deliver mental health and alcohol and other drug care for our community. So we're calling the model Step Through Care, and it's a new integrated model that's been developed in response to community needs and key mental health and AOD reform recommendations, which you've probably heard of, the Royal Commission into Victoria's mental health system. So this work has been, I guess, backed by those key policy changes. So how did we get here? So it's been a 3-year process where we've done a whole lot of research onto best practice models for mental health and alcohol and other drug care. We've also done an extensive consultation process with our community, with GPs, with service providers to understand what the needs of the community are. And then we developed the model and we took it back to service providers to see if they could deliver it. And now we're working with the partners as we discussed. In terms of the vision for our model, so really we want to make a difference across the health system by working closely with our local communities and our system partners to deliver new and innovative models of healthcare. So what improvements have we made on the current mental health and alcohol and other drug services that are available? So the first one is ease of access. Mon's going to talk a bit more about this, but the referrals to Step 3 care can come from anywhere, including self-referrals. So there's no requirements around having to have a mental health care plan or having to have a referral template. They can come from anywhere in any format. There's an integrated assessment process. So all consumers that come into the model will be assessed for co-occurring mental health and alcohol and other drug support needs, and then they'll be connected to the appropriate service based on those needs. There'll be seamless support for consumers. So if they're requiring both mental health and AOD services, they can receive these supports in the same agency. So it'll reduce the bumping around the system to different service providers and also reduce them retelling their story. And then it covers the levels of care across the mental health and AOD stepped care framework. So there'll be services that support people with low-level mental health needs to mild and severe mental health issues, and also alcohol and other drug support needs. And in terms of the providers across our region, so these are the providers that we're working with across all of our regions. So in the Wimmera Grampians region, we're working with Uniting as the lead agency, and then they're partnering with Grampians Community Health to deliver the service. In the Ballarat Goldfields region, we're working with Ballarat Community Health as the lead agency, and then they're partnering with Maryborough District Health Service and Central Highlands Rural Health. For the Great South Coast, so down in our Warrnambool region, we're working with Mind Australia as the lead agency, and they're working with Rad Health, Genu, Brophy Family and Youth Services, and Portland District Health. And then in our Geelong region, we're working with NEMI National as the lead agency, who are working in partnership with Windana Drug and Alcohol Recovery Service, Drummond Street Service, and Watherong Aboriginal Cooperative. So I'm just going to hand over to Mon now to talk through how to refer into the program.
Thanks, Nat. So I guess this is probably key information for everyone here, but how do your patients access step-through care? So from the 1st of July, the current referral process into Western Victoria Primary Health Network commissioned mental health and AOD services will change. So when we talk about these current services, we're talking about the current psychological therapy services, the current severe and complex or the STEPMI program, our current low intensity services and AOD services. So as the new, and this will occur as the new step through care services commence. So referrals will no longer be sent to the West VIC PHN referral point team. Referrals will be sent directly to providers, which Nat outlined in the previous slide. So the details for local referral pathways in your region are all available on the West VIC PHN website, and there's also flyers for GPs which outline the new referral pathways. These new referral pathways will make it easier for GPs and other health providers to refer into step-through care. This can be done in one of three ways, as is up on the slide. So direct patients can be directed to the Head to Health central intake via the 1800 number. A GP or healthcare provider can write a letter and send this in a secure way to the provider in your region, and the details of those referral pathways, as I've just mentioned, are available on our website. Or the GP or service provider can complete a referral form and send this in a secure way to the provider in your region. So referrals no longer require a mental health treatment plan or K10 to access the program. However, GPs are welcome to complete these if they wish. I think Nat has just shared in the chat the links to the Step Through Care referral process page on our website. For clients who are currently receiving a PHN commissioned mental health or AOD service, their current provider will transition their care as required, and GPs will be informed of any changes. Excellent. So the new step through care model covers low intensity through to higher intensity mental health support, as well as AOD support. So in AOD, includes the provision of appropriate care and support across the continuum of AOD use, such as brief interventions, screening and assessment, counselling, dual diagnosis, group interventions, and home-based withdrawals. For low intensity, the eligibility criteria is people who are at risk of mental health issues or have mild mental health issues and do not require more intensive psychological interventions. Then we've got psychological therapy. The eligibility criteria is all priority groups, which we'll go over in the next slide, can access these services as long as they are not duplicative of other services, such as MBS funded services. And then high intensity mental health treatment and care coordination. The eligibility criteria is people with severe and or complex mental health issues can access these services as long as they're not duplicate of other services or they don't require acute services. So step through care is designed for priority groups that have difficulty reaching services. So ensuring access to services to these priority groups is a requirement of the funding. So people from these priority groups will have prioritised access to services. It is free to support those most at risk, so please review these groups when referring. So we've got people on low income, people living in rural and remote communities, people experiencing short-term displacement or homelessness, people who identify as LGBTIQA+, Aboriginal and or Torres Strait Islander, people in areas impacted by natural disasters. We've got culturally and linguistically diverse backgrounds, children under 12, people experiencing perinatal depression, people with an intellectual disability who are experiencing AOD and or mental health issues who encounter barriers when accessing care, people experiencing or at risk of domestic violence, and young people who do not have access to other appropriate support services such as Headspace. So several of our current PHN funded mental health and AOD programs will be ceasing from July 1, which is what Nat and I have gone through in this presentation. So these services that will no longer be continuing are the PTS or psychological therapy services, STEPMI or the Severe and Treatment for Enduring and Persistent Mental Illness program, the Drug and Alcohol program, and the National ICE Action Strategy program. Now, as these programs will not continue in their current form, we've already outlined that they will continue on in Step Through Care. The services which you can see on the slide in yellow, our psychosocial support services and Headspace services are not part of Step Through Care, so there is no change to how GPs will refer to these services. And that's the end of our presentation. If anyone has any questions, please feel free to reach out to your practice facilitator or jump on our website. We've got information about the service and information about referral pathways, including the GP resources and flyers.
Awesome.
Thanks.
Thank you so much, Nat and Mon. Really appreciate that. Now everyone's got to, I'm going to take their names away and you've got to guess which one's which. No, I'm just joking. You don't.
Sharon, can I just interrupt for a quick second?
Sure. Yeah.
So Nat and Mon, I just wanted to let all the practice managers in particular in online and in the rooms know that they might hear or they may have already heard from practice facilitators actually directly reaching out. And asking you guys to let specific GPs know about these changes because they might be common referrers into the programs that are ceasing, or they might still be trying to refer into those programs. So we want to make sure that if you hear from the practice facilitation team, the next steps would be to have a chat with all your GPs or the GPs in particular that the team are letting you know about, just so that they're aware of the changes. We've had a pretty lengthy communication process about the changes, but not everything reaches everyone, and we realise that how busy everybody is. So you might hear from the team and you know what your next steps might be is to have that conversation with all your GPs or a specific GP.
Yeah,
thanks Sharon.
Thanks,
sorry to butt in.
No. Thank you. And thank you guys for coming. I really appreciate that. And if anyone needs more information, please reach out to your practice facilitators. So I'm going to introduce Cheryl now from Avant. So thank you so much for coming.
My name is Cheryl Wood. I'm a risk advisor with Avant Mutual. Prior to joining Avant, I was a practice manager for an anaesthetic group in Melbourne. Prior to that, I was the executive officer of the Inner East Primary Care Partnership, which was a precursor to what is now the PHN. So I've had a varied experience. So I just want to begin today by acknowledging, and excuse me for the pronunciation, Wadawurrung people, traditional custodians of the land on which we meet today, and pay my respects to their elders past and present. I extend that respect to Aboriginal and Torres Strait Islander people who are here today or are joining us online. So what we're going to talk to you about today, and hopefully we get through some of it, is managing difficult patients, occupational violence, patient complaints, psychosocial hazards, sick leave, and then if we've got time at the end for questions, anyone who's present here today, I'll try and hang around a little while afterwards if you've got any particular questions. Feel free to put questions into the chat, and if we have time to answer them or write them on the pieces of paper on the table. If we've got time to answer them today, we will. If not, we can communicate with the PHN to be able to provide that afterwards. So managing difficult patients. So an overview to this is to provide you with some general advice. There are difficult types of challenging patient interactions. We'll talk a little bit about patient complaint management and ending the doctor-patient relationship. So 15% of the clinical interactions with patients are perceived as being difficult by doctors. That also has an impact on practice nurses and practice managers as well, because you'll have a patient who may not necessarily be all that easy to deal with. 1 in 8 Avant claims involved a perceived disrespect towards a patient. Okay, so we're talking about the circle of influence. The concept of the circle of influence versus the circle of concern was first proposed by the late Dr. Stephen Covey in his book, 7 Habits of Highly Effective People. For an example, you need to go out to the shops, but it's raining. You can't control the rain, but you are concerned about it. What you can do is to put on a raincoat, get an umbrella, choose a later time to actually go. So there are things that you can influence, however, you can't influence the rain itself. So what you can control is your attitude towards a raining day. Dr. Covey makes the point that if we want to be proactive in a crisis rather than reactive, we'll focus on the things we can control, which is our response to the situation. Things we can influence, such as having a policy around how we deal with difficult patients. So if you do have a difficult patient present in front of you, you know from the practice perspective how you deal with that. Providing staff with education. We will often advise practices not only provide some education for your staff so they know how to handle difficult situations, but also for those situations, provide them with a script so that they know if they're dealing with something that they've got a script and know how to respond to it. We also need to let go of that we can't influence. Those in our circle of concern, we care about them, but we worry about them, but we can't control them. This would be the patient's behaviour. We really can't control that, but what we can control is our response to patient's behaviour. So we try not to upset patients anymore. If you worry about the things outside your influence, they just end up getting angry, frustrated, and worn down. The circles impact on each other. So the more you worry about the circles of concern, the less control you have over those things. So thinking about, and also with your staff, making sure that you highlight to them you're not going to be able to control everything. Deal with what you can and accept what you can't. Recognise what the issue is. Oh my gosh. So is it the patient? Are you managing the patient expectations? Do you understand what the patient's expectations are? Has the patient had a poor past experience with your practice or people within your practice or other situations? Are they there with a child? Are they there with a worry about their child's health and are concerned? Is it their illness? Have they got chronic pain that's upsetting them? Patients can be uncooperative, they can be hostile, demanding, disruptive. None of you would have ever seen patients like this at all, I'm sure. Although it's important to remember that patients may think that the doctor also shows some of the same characteristics. So being really careful with and talking to your doctors and your staff that if a patient is upset, try to reduce your own response to them. They might have unrealistic expectations or be unwilling to take responsibility for their own health. All these factors can contribute to making an interaction with a patient challenging. Also thinking about, is it you? Particularly when you're talking about receptionists, are they having a bad day? Have they, unfortunately, there's a patient that's been late and now all of the appointments are backed up and they're getting patients come in and they're getting frustrated. Is the receptionist or you, are you tired, hungry? Do you have a personal situation going on that's playing in the back of your mind? Do you keep getting messages from children at home with issues? Try to keep your cool and don't try to win an argument. And that's really where communicating with your staff to ensure that they take some responsibility for their own approach to patients and trying to identify if they are potentially contributing to a patient's response. Also, is it the system? Things that you can't control, such as parking. Patients might be upset because of parking issues. They might have been delayed in traffic. Billing can sometimes be an issue for patients. Wait times, they're things that you can't necessarily change. So managing expectations is one of the things from a risk perspective we will often talk to our practices about to ensure that you're managing the patient expectations. Patients won't always verbalise what their expectations are. If you're aware and they are unrealistic, reinforce the facts. They might have an expectation that I'm here for an appointment, I'm going to talk to the doctor and I want to discuss 4 different topics that are going to take half an hour, even though I'm only in a 10-minute slot. Set clear expectations with every interaction. So certainly we'll talk to practices and suggest when staff might be triaging an appointment, being really clear with patients as to what the doctor can achieve in the time that's set aside. And apologise if needed, particularly if the practice has let the patient down, if the doctor was running late, if another patient has caused some delays and they're going to have to wait, apologise if it's necessary. Often patients just want to hear an acknowledgement and apology. So you need to identify the situation as difficult if this is what you're experiencing. Name the elephant in the room. Verbalising the difficulty can help build trust. Support the patient by listening carefully, showing them empathy. People are more likely to listen if they feel listened to. Be curious. Don't try to win an argument. Try to really explore with a patient what is going on and see if there's something that the practice can do or that you can do to assist. Patients may be upset because their appointment's been delayed and they have to get to somewhere. And again, apologise to the patient. Offer to reschedule the appointment if that's going to help, or if there's any other solution. Oftentimes you can't do anything, but acknowledging and making an apology to the patient. Arguing and talking over the patient or interrupting the patient can lead to a downward spiral in an interaction. Even a difficult patient can have a real problem. So they might be difficult, but they may actually have a problem. Kindness can really take the heat out of an argument, and arguing may just escalate the issue. So other kinds of difficult. So we've discussed demanding, aggressive, unrealistic expectations. Given you can all see the notes, what are other types of difficult? So in our notes, we've identified separated parents. The dad comes in, but the parents don't get on. Can anybody here, given we've got people online as well as here, think about other difficult situations? And probably for time purposes, we won't go through it, but thinking about other things that may be difficult and how you might handle it as a practice, and how you might address that in your policies and procedures. So after a conversation, and our notes relate a lot to doctors, but for staff as well, any interaction that's difficult in the practice can have an impact on everybody. So acknowledge that it does have an impact on the doctor. Maybe it's an aggressive patient in a consultation and that doctor's had a bad experience. Noting also that the patient may come out of the consultation and be aggressive with the receptionists. And ensuring that you try to always stay calm in the experience, but afterwards make sure that you debrief. One, with the doctor, I understand that you had a really difficult interaction with that patient. Is there anything that we can do? Allow them an opportunity to reflect on it, perhaps get them to talk to another colleague, another doctor in the practice, just to reflect on the interaction and what they may be able to do differently in future. Sometimes it might be the patient. Make sure that you document any difficult interactions, particularly from Avant's perspective. If there's a complaint or claim, keeping a record of anything that may have occurred, just so that it can be something that can be reviewed in future. And get support depending on what the situation is. If it's a significantly stressful interaction, make sure you get support. We always recommend that practices have an EAP for their staff as well as for their doctors. Those that are insured with Avant, we do have an EAP type support available for doctors. So direct them towards Avant, and it is confidential. And that said, if they're insured with another MDO, they may have similar arrangements in place. So talking about occupational violence, so grab the right one. So we've got the abusive patient. So when you're dealing with anger or aggression, having the mindset that the patient is a customer is more about trying to help and trying to get to the bottom of the problem rather than seeing the patient as an annoyance. So really trying to give that customer interaction, trying to give the patient a good outcome. For example, I was out visiting a practice one day and a patient walked in really unhappy, unsettled baby on her hip, and the receptionist flew up and said, "Out, you can't come into the practice without a mask." That mother had a really good experience on that situation, and she was just trying to put on the face mask, but she couldn't, trying to juggle the baby. So we would say trying to be understanding, empathetic of the patient and what they might be going through. In that scenario, the receptionist coming out saying, "I understand you're having a bit of difficulty. We do require face masks, but I understand until you can settle the baby that you're going to have some difficulty." So we've all seen these patients. We may have all seen these people in different circumstances. So they might be verbally or physically abusive, confronting behaviour, rude or aggressive, threatening, harassing. They might do it via sending rude emails, on the telephone, and certainly around patients who are abusive on the telephone, we would advise you to talk to your staff. Again, have policies and procedures in place, and a way that staff can deal with these difficult interactions on the telephone. Certainly talking to staff that we don't expect you to deal with threatening abusive behaviour, and perhaps giving them some tools to enable them to either de-escalate or end the phone call if that's what's happening. So we've also got angry patients. So they're often reacting to circumstances. It might be circumstances you're not aware of. It may be something that's in the practice that's triggering to them. Prevention is key. Trying to manage expectations, as we talked about earlier. If a patient walks into the practice and you know you're running behind or the doctor's running behind, don't tell them to sit down and the doctor will be with you soon. Tell them to sit down and say, "I'm sorry, Mr. Smith, unfortunately, doctor's running 15 minutes late. Are you happy to wait? If you're not able to wait, we can reschedule." And if that time extends, continue communicating with the patient to advise, "Look, it's still taking longer than anticipated," and just let them know. The last thing you want is to sit there and expect that the doctor's going to come out in 10 minutes and an hour goes and you're still there. So an awareness of early warning signs. If patients really look agitated, again, go and talk to them, explain this is what's happening right now, and try to manage their expectations. De-escalation, so apologise, offer how can I help, what can we do to make things better, understand where they're coming from, and reflect on your role, and also give your staff the tools to reflect on their role in the interaction. So yes, we're dealing with a difficult patient. The patient is angry for whatever the reason is, and give them some tools as to how they can de-escalate. Certainly over the phone, I used to tell our staff, if you're having a difficult interaction over the phone, put the caller on hold. That can sometimes de-escalate, and tell them you'll put them through to your manager. It may be the receptionist sitting next to them, but they don't have to know that. And just feeling like they've been heard and acknowledged often helps to de-escalate a situation. So again, another one is aggressive patients. So you really need to have safety first. So thinking about making sure that there's ways for patients to be isolated, to be set aside. Leave if you can, or ask the patient to leave. Talking and perhaps running through with your staff as to, if you've got somebody yelling at you at the desk, how do we deal with that? In the moment, it'll be really difficult to refer back to your policy and procedure, but think about what it is that you can do to be able to protect yourself and protect everyone else, because you will have other patients. Whether everyone can leave, keep your distance, enact practice safety procedures such as an alarm or calling 000. So giving staff or having policies and procedures in place as to when some of these things might be put in place. Don't antagonise somebody who's aggressive. Try to acknowledge that they have a concern, see what you can do to try to resolve it, and understand the reason for their aggression, but certainly keeping a focus on your safety of staff, safety of doctors, and safety of other patients in the practice. We'll skip this because we haven't got the time to go back and forth, but thinking about from your own perspective, have you ever been in a situation where you felt your safety or safety of others was at risk? And thinking about how you responded in that situation. Think about whether you had a good outcome, whether you were able to resolve the situation, or where things maybe didn't go quite as planned and how it could be changed in future. Okay, practice insight. So again, ensuring the staff and patients are protected. Whether you have a plan in place for the situation before it occurs, educating the staff, educating the doctors. Often we look at the admin staff and engage them in the process of policies and procedures, but we don't necessarily remember that the doctors could be involved in that. So certainly when you're talking about aggressive patients and how you might be able to manage that, providing the doctors with some tips as to how to do that. Have some acceptable behaviour policies for patients and staff. Putting an acceptable behaviours policy up in the practice, having a message on your on-hold music or your voicemail to say that we've got a zero tolerance for unacceptable behaviour in this practice, but having signage up in the practice so it kind of reminds patients when they're sitting there that this is what they are responsible for doing. Prepare staff well if the practice policies are changed. So let's say you've gone from bulk billing to mixed billing. These are the types of times where you might come up against patients who are aggressive. So ensuring you prepare your staff, provide them with scripts to explain exactly why the practice has decided to go from bulk billing to mixed billing, and how to deal with some of those difficult discussions. You might have a patient that arrives at the practice and they're upset because all of a sudden they have to pay, whereas before they were bulk billed. Your practice may have a policy, if the doctors are happy for that, on that occasion you bulk bill the patient, but explain to them next time you come you will have to pay an out-of-pocket. So thinking about how you might be able to deal with some of those difficult situations in your practice. It can be emotionally draining for staff, so ensure they're well supported, and look at opportunities for improvement. So if you do, we always say, if you have any of these difficult interactions, think about what was the outcome. Was it a good outcome? Was it a bad outcome? If it wasn't a great outcome, what could you do differently from a policies and procedures perspective? How could you manage this a bit differently? Maybe you've got a seat right in front of the reception and that's where this aggressive patient was sitting and they continuously stared down the receptionist. Maybe move that chair so that that can't happen in the future, but looking at how you might be able to make some changes from a quality improvement perspective. Patient complaints. So this is a really big one that practices often grapple with. So we recommend having a staff member responsible for complaints. So it needs to be somebody who has enough authority to be able to act on it, but also somebody who is able to be professional, to empathise with a patient and to talk calmly with the patient to take their complaint. keep a record of the complaint, have a policy and process in place for dealing with complaints. If the complaint is substantial and it's quite complex, we recommend getting it in writing so that you make sure you understand exactly what the complaint is about. When you receive a complaint, we recommend you respond within 24 hours, even if it's just to say, look, thank you for providing your feedback. This is what our process is, and this is what the expected time to resolve that is. And it's worth putting in the effort to be able to deal with patient complaints early. So often patients with their complaints, it's really understanding what it is that they want from it. They want to be heard and understood. They may want an explanation as to why something happened. They may require an apology, or they may require something to change. So one of the things that we talk about is ensuring that you not only have a complaints policy, but you also have a feedback policy. Have signage or have information somewhere so patients know that your practice is open to taking feedback as well as complaints. We recommend perhaps putting something on your website so that if somebody wants to put in a complaint or provide feedback in the evening, they can go to your website and look at it and put that through that way. Oftentimes you might find a patient's had a difficult interaction during the day and they go home and they talk to their husband and say, look, this is what happened while I was at the practice. And the husband will be like, well, you can't accept that. That's not the way that the practice should be behaving. I think you need to make a complaint. If they can go to the website, they may not, but if they can go to the website and see, look, there's an option here that I can lodge my complaint now, they may do that. Because if you do a Google search around making a complaint against a health service or a medical practitioner, really easy to do. You just go in there and make a complaint, and then it becomes a really significant issue, and it can be traumatic for the practice, it can be traumatic for the practitioner, and it can be a really lengthy process. So where you can, it's a really good idea to try to collect those complaints up front and try and deal with it in the practice. If you can, and if it's appropriate, have the patient attend the practice so that you can discuss it face to face. The patient may not necessarily want to communicate with that particular doctor that they've had an issue with. So understanding, again, what is the basis of what the complaint is and try to address it appropriately. What not to do, don't ignore it. Don't assume it's going to go away. Mr. Smith is always like this. He'll be fine in another week or two. Because it may not be. Don't accuse the patient. Try again to be professional. Try and acknowledge that the patient may have a legitimate complaint. They may have a legitimate reason for being angry. And don't tell the patient that there's nothing you can do for them. Acknowledging to the patient, yes, we've received your feedback. We apologise that in this instance we haven't met your expectations. This is what our process is for dealing with this, and we'll get back to you in this period of time. And then to get back to the patient. It may be that nothing can change, but certainly acknowledging, look, Mr. Smith, we have gone through and we've looked at our policies and procedures and we have spoken to all of the staff involved. In this instance, it was a mistake. We apologise. We're sorry that you feel this way. But what we've done is to provide staff with additional training to avoid this in the future. And resolving a complaint. Really, when you're going through and you've received a complaint, gathering all of the information. If it's a clinical complaint, making sure you're looking at the medical records, the copies of reports, records of phone calls, and identify exactly what the issue is and what may have contributed to it. If a referral or follow-up is required, work out a management plan for the patient. So really identifying if it's a clinical or if it's an administrative issue, how that might be able to be dealt with. Psychosocial hazards. So you may have heard of the changes with psychosocial hazards at work. So psychosocial hazards are factors that either are in the workplace or associated with the type of work that's being undertaken, which may have a negative impact on the employee's physical, mental, or cognitive or emotional health. So psychosocial hazards, it's a transition from being an HR reactive response to when something happens, this is how we deal with it, to being proactive from an OH&S perspective to identify and hopefully address an issue before it occurs. So like a health promotion approach to that. So the types of psychosocial hazards, it might be job demands. It might be that somebody has low job control. They might have poor support. It might be a lack of role clarity, poor change management, inadequate reward and recognition, traumatic events or material. They might be working remotely and finding it difficult to do that. Poor organisational justice, so they might not feel that things are being addressed appropriately when somebody else isn't towing the line. Violence or aggression, bullying, harassment, including sexual harassment and conflict. So I'm kind of going through this really quickly. There's a lot more to this than what is going to come through here, but we'll certainly provide some resources afterwards that you're able to then distribute. So the new legislation, there's a responsibility to identify psychosocial hazards in consultation with employees, such as bullying, sexual harassment, low role clarity, poor support, high job demands, and aggression and violence. Eliminate any risks associated with psychosocial hazards as far as is reasonably practicable. So if there is an investigation, Fair Work will come in and request documentation to show that you actually are undertaking these processes to identify and deal with any psychosocial hazards in the workplace. Prepare a written prevention plan for certain psychosocial hazards that have been identified. Employers with 50 or more employees, which probably isn't relevant to this audience, but maybe, must provide a written report to WorkSafe Victoria twice a year regarding whether any psychosocial complaints have been received, and keep a copy of the report for 5 years. So it does put an additional impost and burden on organisations when we're already dealing with so much. So the intention is to ensure that we're looking after our staff and they're not going to be experiencing negative outcomes in the workplace. So when we're talking about managing psychosocial hazards, so one, we identify the hazard. The first step in risk management process is to identify the psychosocial hazard. So this involves identifying the aspects of work and situations that could potentially harm workers or others. Assess the risks. So let's say it is the work task. Maybe you've got a staff member who does billing, is typing constantly, doesn't interact with anyone, but hears everybody else having a lovely time in the office. So identifying this might be a potential hazard for this particular cohort of staff who are doing this work. Assess the risk. So if a staff member is sitting there constantly all day, what are the potential psychosocial hazards? They feel disengaged because they don't feel part of the work environment. Maybe they start to feel like they aren't valued. So identify and assess, control the risk. So what can you do to control the risk? So let's swap the tasks around. Maybe you have a couple of people doing this one task rather than a single person doing it, and swap them around intermittently so that they each get to share the load. Also review the control measures. So we've put in place a control measure and intermittently review, has this actually made an impact? Are there other things that we need to consider in this? Now, I'm aware of the time, so we are going to briefly discuss sick leave. Joe Biden's disappeared now. So we do have a video that I'm not going to play, but we can probably share that around just from our workplace employment team. who provides some tips and tricks on how to deal with this in an organisation. One thing that we also talk about is excessive sick leave. So as a manager, staff taking excessive sick leave can be annoying. It can contribute to issues with the rest of the team who think, well, this person takes every Monday off at the start of the month and it's really annoying and they just expect it, and can cause issues in the practice. So we would advise that you be proactive with staff. Approach them from a position of caring and wanting to have their best interests at heart. So being proactive. John, I noticed that you seem to be sick on a Monday at the start of the month, and that particular day might be a day that a particular task is being done. So talking about what it is that might be happening, just to identify, look, I've noticed that you're taking all this sick leave. Is there anything that is causing any issues within the practice? Is there something that we can do to assist you with this? If he says, look, I have an issue on that first Monday of the month, my child has to be at this in the morning and therefore I find it really difficult to arrive at work on time, it's easy to take the day off. Identifying what it is and being proactive. Identifying what it could indicate. If the staff member is doing a particular role on the days that they are taking sick leave, if there is a pattern, if you identify, trying to identify whether it's potentially something within the team, whether it's the task that they're having difficulty with. They might have a legitimate illness or injury. So investigating that, identifying whether there's anything within the practice that you can do, whether it might be adjusting the tasks and the roles that they're doing. If you have a concern that it might not necessarily be legitimate, requesting a medical certificate, and you can request a medical certificate for every day that they take off. You can also, if you don't think that the medical certificate is valid, contact the doctor just to confirm. You only need to call the doctor to say, I've received this medical certificate, I'm just confirming that it is valid. And the doctor will say if it's not. If there's no reasonable explanation, you might consider putting in place or advising the staff member, this is what the expectation is around attendance. Maybe require that they call you rather than send an email or send an SMS, just so you can monitor and talk to the staff member when they're taking leave. Continue monitoring absences. If you need to put in place a plan, give them a plan, this is what we need to do, and get back to reviewing it regularly. You might need to undertake a formal process. And also, if you believe if it is a legitimate illness and you believe that there may be an issue, you can actually require the staff member to attend an independent medical examination. If you do request a staff member do that, we generally suggest, if you do have practice insurance, to perhaps contact your MDO and seek advice before you go through such a process. Same if you're going down a performance management process. And at that, we are up to the questions.
Thank you.
So apologies, that was really rushed. And lots of overviews of everything.
Well, Cheryl has just given us an example of how to be calm under a stressful situation. So well done, Cheryl. Is there any?
I had Jill on my side.
You did a really good job. Is there any questions that they could answer now? If not, I can get them if you don't mind, and perhaps give you an email.
Yeah, no, by all means.
If that's okay. But yeah, you've done really well. Thank you. And I apologise. When I was at home, it presented quite well. So yeah, so we'll have to go back and have a little look at that.
That's okay. Thank you. But I will hang around for a little bit for those who are here. Thank you for having us here. Again, if you have Avant practice insurance, the risk advisory service is something that's freely available to members. So, and there's lots of resources around all of this. Whether or not you're with Avant, go to the website and look up the resources. We've got some really great education materials.
I don't know, find out.
Oh,
Sorry.
hi, Kim. Yep.
Yeah, we have a question. Let me know if you can hear.
Can.
Cheryl, can you hear me?
Yes, I can.
Okay, the question I have is, you kind of raised a thought to me that is it appropriate that if we're putting on a staff member, that we get them to do a K10 or questionnaires about their current state of mental health? Is it appropriate that we can actually ask about current stresses they've got in their life, expectations, or other things? Because a lot of the things you were pointing out to me, sometimes not work related, but can sometimes be the personality or other issues that might be going on. So how appropriate is it that you can actually do, you know, when you do a performance review, you can actually ask them to also redo these to also get a baseline as well as an ongoing view of, you know, issues that people have?
I would say, and this comes into our workplace legal team, so I'm not going to put my hand up to say that I have that advice, but I would be very cautious about asking people about their mental health or any stresses at the time. Generally speaking, when you're employing a new staff member, you do ask them if they have any pre-existing medical conditions that the practice needs to consider. Maybe when you're asking those questions or on your documentation saying whether it is physical or mental or psychosocial, that may be, and it'll certainly be kept confidential, but I'd be really cautious about the way you ask those types of questions. It might be worth looking at your policies and procedures around your onboarding and seek some advice from an HR lawyer just to make sure that you're not actually seen as potentially putting in place discriminatory practices.
Yeah, which absolutely makes sense. But it's more that we've actually had sort of an issue in the past with a person who actually had quite a lot of issues going on, and they sort of put them through the business and sort of continued with all these behaviours and things that actually were not helpful on anybody's part. So you kind of wonder how you can do it with, obviously, you know, I've got a nursing background, so I'm not going to be doing it from a, you know, discriminatory or setting up, but it's more that baseline. You know, if you took someone's blood pressure, it's probably no different than working out what their anxiety levels might be for certain things. So I kind of agree that you definitely have to delve into it more, but, you know, is it sort of setting it up for those kind of things that we'd have to look at in the future?
Absolutely, and certainly when staff start, it's really maybe checking in with them quite regularly at the start and try to monitor and see if anything within the work environment is causing them any stresses, and touch base with them regularly. We certainly would be recommending going down performance management processes, or at least putting in place a code of conduct. And reminding staff about what the code of conduct is and the expectations of them in their employment situation, and where they're not meeting that code of conduct, then talking to them about that and identifying what they or the practice can do to try to meet those expectations.
Excellent. Thank you, Sharon.
It's okay. Thank you for your time. Thank
Thank
you.
I think Cheryl deserves a bit of a round of applause. She's done really well. So thank you. Thank you, Cheryl. So I'll let everyone go and do some networking if there's no more questions. Thank you, everyone, for coming. I know we've got some slice here at Geelong. Don't know what you guys are eating over there. I'm sure it's something yummy, but feel free to have some and continue talking. Thank you very much.